It is my brief today to try and take you through the path from suspicion to diagnosis. So I'll be touching upon some aspects, and let's see how clear I can make myself. So bone and joint infections account almost for 5 to 10% of childhood infections, and it is, I think, it behooves every pediatric orthopedic surgeon and in fact every orthopedic surgeon to impress upon the medical community that early diagnosis and prompt treatment can prevent deformity and late disability in a big, big way, very important in a country like ours. So the path from suspicion to diagnosis really comprises of the following things. You really need to take a good history and note the clinical features. You must understand a little bit about the etiopathogenesis, the common microbial organisms involved, order relevant investigations, and then decide your intervention. In recent years, there's a lot of talk about what option will you choose. Will it be just an aspiration and lavage? An arthroscopic lavage, a little difficult thing to do in small children, but sometimes in older children they do talk about it. A USG-guided aspiration, but to my mind, there's nothing but better and nothing more sufficient than a good open arthrotomy, especially in septic arthritis. So when will you suspect acute septic arthritis, really? When the child actually comes with a refusal to move a joint or use an extremity. They may or may not have amount of pain. Any age child will definitely stop using the extremity when there is a big burden of infection. Neonates, and particularly small infants, they may manifest as a refusal of feeds and just total apathy or excessive drowsiness. And any attempt at moving the child, especially changing diapers, the mom or the nanny may tell you that they are exquisitely painful. Please do remember that neonates, especially the low birth weight ones, may not manifest all the signs of a toxic sickness. And sometimes there's barely a history of a little bit umbilical sepsis, some hyperbilirubinemia, or if it has been a stormy neonatal period and the child has been in the NICU, the fever may or may not be there always. So what happens really in this? There's a history of a rapid onset. Within 2 or 3 days, the child kind of starts crashing down. There may or may not be a systemic illness. Very often, if you really dig deep, you will find something. And since these are vulnerable, and if it's a superficial site like the knee, elbow, or the ankle, you may see an effusion developing after the 2 to 3 days of the inoculum from some hematogenous focus in the body. But if it's at deep-seated joints, particularly where the epiphyses are involved, for example, the hip and the humerus, that's where the million-dollar question and our role really becomes very, very important to catch it in time, drain it in time, and prevent sequelae. So what will we see? In small children, you will see, especially if it's the hip or the knee, you will see the hip is flexed, abducted, and externally rotated in a position of maximum capacitance. If you have not looked for lesions, please strip the child completely and look, for example, in this child, we saw that there was a staphylococcal infection all along the back. And a non-usage of the affected extremity. If you can't really test for it, always do this, what I call a suspension test, as you can see out there. The child is barely moving the left leg, but really fiercely kicking the right one. And that gave us a clue that this joint needs further investigation. So what should we really be ordering? There is a lot of talk about lots of markers of infection these days, but the good old criteria of Sydney NATE still hold quite true. And let's look at the role of some of the investigations as briefly as we can. So WBCs, CRP, and blood cultures are absolutely vital. ESR in our scenario is not really very, very relevant. WBC counts in a neonate can be elevated greater than 12,000 is what literature says, but our pediatricians tell us that between 12 to 16,000 is pretty normal for a neonate. So in a neonate, do interpret it with caution. If it's an NICU child, then you may have neutropenia, and hence you may not get these counts. So as long as you have a clinical suspicion, you can go ahead and suspect septic arthritis. The CRP is not really a diagnostic marker, but more of a titer which tells you how well this is going to do, how well it rises, and how fast it falls. That's more important in judging how your treatment is doing. And please don't forget to obtain blood cultures if you're lucky, and if the pediatrician has not already started and bombarded with heavy doses of imipenem and meropenem, which tends to happen these days. And hence you may get it positive only in 40 to 50% of the cases. So what holds good today also is the Cocos criteria, that is fever above 38 degrees centigrade, inability to bear weight on the affected not leg really, limb, or let's say refusal to move that part. ESR greater than 40, which again we will not really apply to the Indian scenario, but a raised WBC count. Any of these 3 points, if they are positive, then the probability of the septic arthritis, especially the Tom Smith variety, is greater than 93%. And hence, in the recent years, what has happened and has become really the gold standard for young neonates and infants is the ultrasound, which is like a stethoscope of the orthopedician, to say so. You look for soft tissue changes. The elevation or the thickening of the periosteum in a good sonologist's hands can be seen as early as the first 24 to 48 hours. Do not rely on X-rays because bony changes take very, very long to manifest, and by then you may miss the bus. For example, in this child who was being seen by a pediatrician, given a lot of antibiotics, and this X-ray was passed off as normal. It's only when we did the ultrasound that we found the hip was totally dislocated, and you see a lot of collection in the area there. On a retrospective look, we already saw that there was a periosteal reaction here. So within 15 days, the changes had manifested and osteomyelitis was already rampant. And this further ultrasound showed you in various degrees of destruction, and that's your femoral head and the ultrasound showing a lot of granulation tissue there, almost destroyed. So these are examples from 3 or 4 different children where ultrasound clearly demonstrated the presence of septic arthritis. What are the commonest pathogens? If you're lucky enough and you're able to aspirate before the antibiotics are started, you can look at some of these pathogens. Commonest is the Staph aureus, E. coli and Klebsiella follow, especially in NICU children. And if it's a hospital-acquired infection, Pseudomonas. So hence, microbiological diagnosis depends on getting the good inoculum, and it must start before, you must do it before starting therapy. It's positive in about 50 to 70% of cases. It's important to try and needle biopsy from the joint if you're not able to aspirate or if you get a dry tap. Even a good 16, 18 gauge needle can give you sufficient sample and inoculate it directly into the blood culture bottles, and PCR should be done. If you just stick, as far as intervention is concerned, to aspiration, of course, it's a shorter and probably an OPD basis procedure. Pediatricians and parents will always be very reluctant for a major procedure. But do remember that there are instances of dry tap. You will not be able to visualize what is happening inside the hip joint in particular and the cartilage, and you may miss the metaphyseal lesion. So hence what I would recommend is make it the first step of your surgical armamentarium to obtain a good tissue sample and then proceed with your arthrotomy. And arthrotomy, on the other hand, if you just toss a coin and look at the positive sides, although it's a little longer procedure, it gives you a complete visualization of the joint. You can do a thorough lavage. You can combine it with drilling the osteomyelitic focus, and you can provide continuous drainage and re-irrigation if needed. So to my mind, it's never overkill. Hence, you must try and have a high degree of clinical suspicion and go ahead for an emergency arthrotomy when you feel that even without investigation, if you feel this is septic arthritis, you can go ahead. Combine it with rational and appropriate antibiotic therapy. And in a neonate, please do remember that acute osteomyelitis and septic arthritis are almost clinically synonymous, and hence basic investigations would be good enough. I think I would stop there as my take home, and any questions.